So the case studies, Millie?
The presentation, I meant.
I haven't got a copy of the present.
That's fine.
I haven't got a copy of it, Millie,
I'll
don't
share
think.
my screen. It's fine.
Okay, thank you, yeah.
Right, let me just... Oh. Bear with me. Right, can everybody see that?
Yep.
Fantastic. Okay, so obviously I've just introduced myself. I'll also introduce my colleague that I've got here with me today. So I've got Emma Garner, who's one of our social workers currently and moving into a consultant role very shortly. Oh yeah, I will just invite her back in. She's just lost contact. Okay, so I'll get started. So I'm briefly going to cover, bear with me, Tracy, could you invite Emma Garner back in? Because I can't get back to the Teams call, sorry.
Yeah, we'll do, yeah.
Thank you. I'm briefly going to cover some of the legislation that kind of leads up to the threshold matrix and its creation, really. So working together to safeguard children, a lot of you will already know, is the statutory guidance that underpins how we work with children, young people, to safeguard them from abuse and neglect. Initially published in 1999 and revised in 2006 following the inquiry into Victoria Colombier. It's aimed at all practitioners who are working with children and underpins how we practice on a day-to-day basis. So it's informed obviously partially by the Children's Act, within which there are 3 safeguarding partners that are outlined who have a duty to work together to safeguard and ensure the welfare of children within their area. So Section 11 of the Children's Act outlines these partners. These partners consist of the local authority social care service, the clinical commission group within health services and the chief of police. Which kind of brings me on to the MASH, which is how this is used in Suffolk. So the working together document has led to the creation of the MASH. The MASH has a multi-agency concept to help provide with a sort of a holistic view of the child and young person or adult's life who's at risk. It enables close working relationships between lots of professionals. We work with a lot of different partners, which enables us to give sort of a quicker and accurate analysis of risk, and it provides a single point of contact for any unallocated cases. So just some very, very rough stats, because we don't want to get bogged down with stats. Suffolk MASH receives roughly 20,000 contacts every year, which relates to 40,000 children, again, roughly. Approximately 80% of those contacts result in an outcome other than a social work assessment. So 80% of those are generally dealt with by MASH and in alternative ways, such as information and advice or alternative actions. The contacts that we receive come from pretty much everywhere. This is just a sort of basic representation of the percentages that we receive from different people. As you can see, the majority of our contacts come from police and education. We also receive a good portion from health and from family members and members of the public. Then we also have other referrals that come from other sources, but they're in much smaller numbers. So what I'm going to do is I'm going to pass you over to Emma, who's going to kind of go through our referral journey and explain how that all works in practice.
Thank you. Sorry, I can't get my camera on now. I've rejoined, so I don't know what I've done. So just bear with me. So when a referral is made, it will go through to the customer first team, and any allocated cases that are open for a social work assessment or on a child in need or child protection plan or child in care will go to the allocated social worker. If the child is unallocated, the referral will be triaged by customer first and come through to the MASH. If there is an open CAF for the family, the referral will go straight to the lead practitioner, the family support practitioner, unless there are high risk or immediate kind of safeguarding risk and concerns. So when a referral comes through to the MASH, it will go into what we call the incoming hub. And in the incoming hub, we have a consultant social worker and one of our MASH practitioners. Between them, they will triage the referrals that come in and make an initial decision on what needs to happen with the referral. So there are several possible outcomes, which you can kind of see on the flow chart there. So the referral will either stay in the incoming hub, go to the assessment hub, or go into the red hub. So the incoming hub will stay in the incoming hub if there are kind of low level concerns, or if we kind of need a bit more information, and there will be a very short piece of work completed in the MASH, for example, a phone call to parents or a phone call to the referrer. From following that short piece of work, we may be able to outcome the referral at that point, either with some information and advice or some signposting. Should the referral or the concerns need some further exploration, the referral may then be passed into the incoming hub for a MASH assessment, in which case either a social worker or a MASH practitioner will complete that assessment with some oversight from a consultant social worker. And there are several different outcomes, as you can see, for a referral that's been in the assessment hub following the MASH assessment. And they are that some information and advice is given either to the referrer or the family or whoever is relevant for that information to go to. The outcome of that referral might be for a CAF, for a family support practitioner to support the family, or potentially for a social work assessment, depending on the kind of level of risk and things, which Millie will go through shortly. So a case will go to the red hub if there are high risk and immediate kind of risk safeguarding concerns, for example, a child that has been harmed. And in the red hub, there will be a MASH assessment similar to the assessment hub, but this will be completed by a social worker rather than a MASH practitioner. Obviously, a social worker has kind of different training to the MASH practitioners. A case that's in the red hub will be considered for a threshold discussion, and that will take place between the three main safeguarding partners, which is social care, so that will be one of our consultant social workers, a partner from MASH Health and a partner from MASH Police. And in the red hub, again, there will be a threshold discussion, and depending on the outcome of that, again, several different outcomes: information and advice or CAF, social work assessment, or potentially section 47 child protection inquiries, depending on the individual situation. So here, obviously, as Millie and I have both mentioned, here's a list of kind of partner agencies that we work with within the MASH. It's not an exhaustive list. The three main safeguarding partners are in the top in green, and just below in the kind of orangey colour are some partners that we do have links within the MASH. The three at the top in the green sit permanently within the MASH, but the others we do have close links with and often request information from or liaise with during the process of an assessment.
Thanks, Emma. So obviously Emma's just summarised sort of how that referral process works. MASH uses a RAG rating, which consists of a red rag, an amber rag, or a green rag. We also have the blue, which is sort of means it doesn't even meet the threshold for it to be considered, essentially. So I'll cover these in a little bit more detail going through, because they link very closely to the threshold matrix and how we apply that. But the timeframes upon them are, if it's ragged as a green, so a level 2, we have 72 hours within the MASH to process that. If it's a level 3, we have 24 hours, and a level 4, which are the red cases and obviously our highest risk, we have a 4-hour turnaround on those. So the threshold matrix. The threshold matrix was compiled by the Suffolk Safeguarding Partnership and their partners, in line with the Working Together to Safeguard Children documents. It's designed to help identify when a threshold has been reached and indicate when a family may need additional support and how best to get that for them. It's aimed at anybody who's in contact with children and families who has a concern. It's there to support people in their decision making on whether something whether a family does require an additional service or whether additional referrals need to be made. And obviously contact with ourselves should that be required. It's a guide for decision making. It's not exhaustive, but and not intended obviously to be a tick box exercise, but more as a guide to support decision making. This is just sort of a very brief guide of the levels that the threshold matrix covers. So we briefly touched on this because it links so closely with our MASH colours and how that works. So level 1 is a universal service. Level 2 are low risk to vulnerables, families or children. Level 3 are medium risk, so high and complex needs, ranging from early help to child in need. And level 4 are high risk or acute cases that we're looking at sort of statutory response and often child protection level inquiries. The assessment triangle informs kind of the threshold matrix, and the threshold matrix, if you've had a look at it, you'll see it broken down in to reflect the areas of the assessment of need triangle. So the threshold matrix breaks it down into child developmental needs, parenting capacity, and family and environmental factors. Underneath each of those headings, there's a lot of different sort of points to cover a wide range of needs for families. You can see sort of coming off of those, off the assessment of need triangle, some of the areas that we sort of are covered. So I'm going to go through a sort of a brief description of what's within the threshold matrix. The threshold document itself is about 18 pages long, so I'm not going to go through each point, but it's just really to get an idea of how we'd be looking at each level. So level 1 are children with universal needs. So the children within these levels are achieving as we'd expected. So there's not concerns in relation to education or health or their well-being at home, or if there are needs, they're low level and can be supported via the universal services that we have in place. Again, I've pulled a couple of points from the threshold matrix to give you some examples. So we're looking at health needs being met, good attendance and achievement within education, good attachment, no concerns in relation to parenting, children are appropriately presented, including good levels of self-care and personal hygiene. Their basic needs are overall being met, and no additional support is needed. Level 2, so these are families who are considered low risk to vulnerable. Again, we're looking at targeted support services or early help services. Some of the things we might see within this is inconsistent healthcare appointments or inconsistent health needs being met, some delays in developmental milestones, some concerns around educational attainment or attendance, concerns around parenting and where some additional support is needed, low level mental health, concerns around children's presentation, concerns around basic needs not being consistent, inconsistent parenting, family relationships not always being stable. There's also concerns around homelessness and or finance, but we're talking about the sort of the lower level of those concerns, where they're starting to begin to have concerns, but not necessarily chronic concerns at that point. So level 3, so children at this level have diverse and complex needs, and targeted multi-agency support services are required to support them. These are cases that range from early help support up to child in need support as a general rule. We're talking, again, cases where there are ongoing health issues or poor management of health issues, consistently poor attendance at nursery and school, or they're not achieving to where we'd expect them to developmentally, concerns around mental health, self-esteem, behavioural issues, persistent, disruptive and challenging behaviour, lack of stimulation, family relationships being quite negative or at risk of breakdown, parent not managing or struggling and struggling to provide a consistent care or not maintaining changes. there being an ongoing history of concerns with the family. Again, housing and financial difficulties features. This is where we're talking about them stepping up a little bit and being a little bit more chronic and a little bit more impactive, and there being a lack of community support and poor access to resources for that family. So level 4, the highest level cases that we are dealing with. So these are cases that generally are subject to a threshold discussion within the MASH, and we're looking at whether the child protection sort of thresholds are met, and these are the children we're considering in this. So there's complex or acute levels of additional need, or a specialist and statutory intervention is required to stop the child from experiencing significant harm or being at risk of. Again, a range of different things that get covered within this. We're talking severe and complex health needs, failure to thrive, evidence of significant harm or neglect, non-accidental or unexplained injuries, child unable to access education due to parental neglect, severe emotional and behavioural challenges. We also cover a number of quite specific subjects, so unaccompanied refuge and asylum seekers, specific identified risks such as female genital mutilation, forced marriage, honour-based abuse. I think that's meant to say CSE rather than CSW, I apologise. So child sexual exploitation, trafficking, modern day slavery, extremism, they're all cases that would be considered at level 4, at least in the first instance. They're cases where we're looking for physical, emotional, sexual or neglect concerns that are ongoing and impacting on that child's safety levels. Again, a couple more examples, but I think kind of that's the overall idea. Is there children that we are significantly concerned about? Right. So we've got, as Tracy said earlier, we've got a number of case studies. I think Tracy's going to break you out into some breakout rooms. There are, I believe, 5 case studies. They're examples of what MASH may receive, and I think are useful for opening up some discussions for definite. They, I think, use the time to kind of have a look at what more information you'd like to know about the case, how you think you'd be able to make a decision about that with what information's available, and what threshold level you believe that would sit at. We'll give you sort of, I suppose, 5 or 10 minutes, Tracy, and then we'll come back and have a bit more of a discussion on each case and go through each one. So you could allocate somebody from each group to feedback as well. That would be really beneficial. And then, yeah, we'll have a chat.
Okay. How long do we say, Millie? Sorry.
5-10 minutes.
5-10 minutes. Yeah. Okay.
I think so.
Yeah, I just, people have said that the link isn't in the chat, which is strange because it's in mine, but I've put everybody into groups, and I have identified one person from each group, so I will send the case study to that person so they can share it with everybody else. Okay, so we'll yeah, you're all in the group, so we'll open them now and then come back in. We'll bring you back in 10 minutes. Yeah, okay.
Right, it looks like we're all back, so we'll go through some of the case studies and just sort of get your views on where things sit and what you'd want to know really about each case. So the first case study, for those who didn't have it, was for Rose. So it's a mental health nurse raising concerns for Rose, who's aged 16, due to anger issues in the home, and the impact on her younger siblings, who were 6 and 15 and autistic. She'd presented at A&E due to anger issues, which are only being seen in the home environment, and there were concerns for safety as Rose would damage the home and threaten to harm herself in front of her siblings. No previous history with social care, and with MASH, no previous MASH history either. So do we have somebody from group 1 to sort of feedback your thoughts?
Yeah, I think I got voted for that as I got sent the stuff. So Rose, do you want to go through what we'd want to know?
Yeah,
first
that'd
of
be great.
all. So we're obviously a bit unsure because we don't have a date of birth. What's the star next to her?
Sorry, the star is because we've anonymised all the case studies. So
Okay.
these are real
Okay.
case studies, but not real names.
So because she's 16, we don't know whether she's at school or not because of her age. So we'd want to know if she's in school, is she attending, how she's doing in school, and if she's at risk of being neat, etc. She may even have a young person's worker if she is already. So yeah, that's a bit around the school, possibly siblings' school, whether there's any changes there with their behaviours. Why is she under a mental health nurse? Is it because she presented at A&E, or was she under a mental health nurse anyway? Because that's unusual to present at A&E due to anger issues, unless the parents are just desperately crying out for help. If there's any other professionals involved, how the parents are dealing with it, when the behaviour started. Is it response to family environment? Is there a mental health professional? I probably think around how serious is the self-harm, or whether she's threatening, or whether it's actual. So it would be more of a mental health professional. Is there, because it says there's no other social care or MASH history, but has she been referred to the emotional wellbeing hub, or that's a possibility? Yeah, why she presented to hospital with anger issues. But we would think about it being a information and violence and a guy's stroke broke a calf. So it'd be a level 2. Whether it would get to CAF, I'm not so sure if it's around mental health or whether it's more around what's going on in the home. So again, not being sure how much MASH. I'm not sure how much MASH ask questions.
Yeah, you too. Bye.
Yeah, I mean, that really is, I think, the biggest part of our job is asking those questions. But so I'll kind of explain what happened in relation to Rose. So as you said, I think it came in initially as a task in incoming to have a conversation with the family to clarify what support was in place. And have a look at whether a CAF would be appropriate. On the telephone call to Mum, she advised that she was no longer able to keep Rose in the home because of the concerns. It was therefore progressed up to a level 3 and an amber within the MASH, and the outcome was actually for a social work assessment.
Right.
Because
Okay.
of the level of concern. But that was based on the information we obviously obtained, rather than based on what you had in front of you.
Okay.
So yeah, I think it was really good sort of starting point. Is you kind of hit where we'd usually hit. We're based on the information we had initially on that one. So fantastic. I'm going to hand over to Emma, and we're going to sort of alternate case studies. So I'll pass over to her for case study 2.
Thank you. So number 2 is 14-year-old Alan. So we had a referral from school raising concerns that Alan has admitted to using alcohol and smoking to help deal with his depression. He's also cutting himself regularly. Alan has got upset at school and had been accused of asking another student for a nude photo. Dad was made aware of the referral by the school and was described as being quite supportive. And again, there's no previous MASH or social care history for Alan. So who had Alan and wants to go through their thoughts? No one have Alan? No? Anyone want to give any thoughts? No? Okay, well, I can just go through Alan then. I don't know if he got missed off the list somehow. So Alan was in the incoming hub for the MASH practitioner to speak with his dad. During that discussion, Dad advised that there is some support in place from mental health services, obviously regarding the self-harm that was mentioned in the referral, and school are kind of exploring the accusations and addressing the concerns under their policies. That's the accusations around the nude photo. Dad has provided details of a primary mental health worker that's working with Alan, and they're exploring kind of ongoing support for him. So the outcome of this was info and advice. So it was closed following that call in the incoming hub. And the reason for that is obviously, whilst there are worries regarding the kind of drinking and smoking, there is mental health support in place, and that's not something that would be hugely unusual for a teenager. And MASH have asked school to have fed back to the referrer, which is the school, and asked them to kind of follow up with that in the first instance. So that was the outcome for Alan. And back over to Millie.
So have we got somebody from room 3 for Alice? I'll just check in advance. If not, I'll just go through.
In room 3, we weren't actually sent any case studies.
They were all in the chat, so you should have had access to
We
them in
didn't
that.
have them.
You didn't have access. Okay, I can only apologise for that. So I'll just whiz through then, and we'll go through Alice and sort of gather people's thoughts sort of live as such. So the case study for Alice was a referral from college. Alice is 17 years old, and she's disclosed that the mother's partner grabbed her around the throat and tried to strangle her. So the incident happened 2 weeks ago. Mum had photographs and marks and bruises that Alice had sustained from the incident. Mum visited housing to ask for support with being rehoused. Alice had been staying with a friend for a week, but had then returned to the family home. No previous MASH or social care history. Does anybody have any initial thoughts on how this would be sort of treated?
I would like to know if mother's partner is still in the family home. It's not clear whether he's there or not now.
A threshold discussion in the MASH, I would have thought.
I'd want to know if he's got a history, so hopefully you would have the name on the full referral, you'd have the name of the partner, so obviously in the MASH you'd be able to see if he's got domestic violence history, if he's currently with probation, been supervised.
This is a potential assault here, and there's potential evidence for it, so I would have thought the police would want to assess that.
High and immediate risk with hands around the throat as well.
And the fact that she's now returned to the home.
Are there any other children or vulnerable, people in the home?
Has he attacked mum? Well, it says no previous MASH. Presumably if he had attacked mum, it's not been reported, because otherwise the fact that she's a parent with children, would it come up? It would have come up, wouldn't it?
The likelihood is it would have done, yes.
Yeah.
The fact that she hasn't reported this incident either to the police.
Yeah, it's come from college, hasn't it? Not from the police, and not from the housing people either.
No,
Although
it
mum
hasn't.
might not have been very clear with them about why she wants rehousing, I don't know.
I'm not an expert in this. Is it not also a domestic abuse situation now? Alice is a child and she's covered under the Domestic Abuse Act, that she's a victim of domestic abuse. So does that?
She's over 16, and it's
child abuse, no?
So that would be a domestic abuse situation.
But as you said, it would also come under child abuse, given that she's still a child.
Yeah, I was going to say I'd hope that we'd be looking at it as a social work assessment at a level 4. Because yeah, threat to her life. If he's still in the house is imminent, isn't it? Potentially, if he's tried it once, the risk he'll try it again.
Yeah,
it's a failure to protect from mum's perspective. She hasn't reported it to the police. Although Alice is 17, she's still classified as a child. She's gone to housing, but you know, as others previously have said, there has been no notification to the police of what's happened to Alice in the family home.
Which might be because mum is also a domestic abuse victim of this man and she's completely petrified.
So would this be a section 47 where you'd have a joint investigation with police and social worker assessment?
So I'll go through the outcome because I think you're all really on target with this one. So initially this case came in and it was initially Bragdon Amber. However, that was without the information that she had returned to the family home, where suspect was still in the family home. So it was initially triaged as an amber, given that the assault happened 2 weeks ago. So that does not mean that a threshold discussion wasn't being considered. It just means that because the assault was an old assault and there was no current evidence of that, we had a little bit more sort of capacity to explore it. However, the minute we found out that she'd returned to the family home and the source of risk was there, that was upped to a red, and decision was made very, very quickly. You're correct in that it was a joint section 47 inquiry. So Alice was seen the same day, as was her mum. Again, hit the nail on the head that mum was also a victim of domestic violence herself. And she'd been seeking alternative housing as that was the only thing she knew what to do. She'd removed herself and the child from the house for the week. But after being told she couldn't get any additional support from housing, she'd felt that she had nothing else but to go back to the home. There was initially when this information came through from the college, as you said, was obviously doing police checks and probation checks for mum's partner. We had no details of mum's partner at all when this initially came in. So it's quite a good example of how we're sometimes working with very, very limited information or missing information altogether. The college didn't have details of mum's partner, and we had to make sure we established safe contact with mum in order to obtain those. So they were included within our overall decision making towards the end of the joint section 47 decision. However, we had to do a bit more digging on that one in order to get those details. And I'm afraid I can't remember if he did have prior history, so I'll apologise for that one. It was also completed as a fast track decision. So a fast track decision is made when we need a response quicker than our information gathering can be, essentially. So given that she'd returned to the home, police and were very obviously keen to get out to the house there and then so that they could remove the suspect. So the decision was made fast track due to that level of risk.
And I just wanted, oh no, that is me, I'm echoing. I just wanted to add as well that when it says there's no social care history, that will mean that there's no social care history in Suffolk. It may be that there's social care history in a different local authority, but because each local authority uses their own kind of recording systems, it's not one universal system. So if it becomes apparent that there is kind of recent or even current involvement from another local authority, we can during our assessment contact that local authority and kind of ask why you're involved, what were the concerns, what's going on. So yeah, when it just to be aware that just because it says there's no social care history, it may be that there's history elsewhere.
Yeah, definitely. Okay, pass to Emma for case study 4.
So we've got Taylor, who is 5 months old. There's not very much information within this referral, but that can be quite typical for our 111 referrals. So it's a referral from the NHS 111 service, raising concerns that 5-month-old Taylor has been dropped on her head by mum. There are worries about mum's response and seemingly unconcerned about the impact on Taylor. Who had Taylor? Who's going to feedback for Taylor? Yep. Hand over. You're on mute.
Thank you. Failed at the first hurdle. So Taylor, yeah, we talked about this. As you say, there's a bit of information. Obviously, it's very scant information, but we felt it was, if you're looking at the 4 levels, because you've got an immobile child who cannot communicate, that it would be a 4, and obviously it's a head injury. We were kind of, the good, I suppose the good bit is that there was a 111 referral, that somebody did ring 111, though it's not clear who that was, if that was mum or not mum. So you say the accident's happened or whatever it is, so it's an injury that you don't know how it's happened, exactly how it's happened. There's not enough about the circumstances. Was it intentional? Was it an accident? And then it says there about the concerns about mum's response, which we thought, well, I think in the group we sort of talked about a couple of options. Either it could be the fact she could have a learning need, or she could be postnatally depressed. You know, she might have her own postnatal issues. Clearly the baby's only 5 months old. We did have a brief discussion about getting Taylor to hospital, saying that, you know, some parents would just, you wouldn't even bother with 111, you'd get there, but obviously it might be that mum didn't have transport. Mum might not have been the person that contacted 111. We really don't know, but we definitely felt it was a level 4. So red.
Yeah, and that's the nail on the head, really. We brought it in as a red, obviously, as you said, a very young baby. We don't know the extent of the injury, and obviously there were concerns about mum's response, which needed exploring. So we brought it into the MASH and asked our MASH health colleagues to complete some checks, and that would include things like looking at whether Taylor went to hospital or whether advice given by 111 was followed following this call, and just kind of to have a look at what recordings are on the health records. So following those checks that health completed, this was actually downgraded to a green, and that the reason for that is that the ambulance service didn't refer, and they didn't have any safeguarding concerns, and they did see both Taylor and mum, so it was not deemed that there was a further role for safeguarding. So the outcome was information and advice. On this occasion, MASH didn't speak with parents following completion of the health checks because it wasn't deemed appropriate. Obviously, 111 was called, the ambulance attended. You know, it seems like a nasty accident and an unfortunate accident. There was no evidence that it was kind of an inflicted injury or anything like that. It's also added that obviously, as highlighted, the 111 referral was very limited. The information that we've got is limited, and it turns out that Taylor had fallen forward on mum's lap and onto the carpet on her face. Obviously, as I said, accidental, and there's no kind of previous history. There is a health visitor involved given Taylor's age, and the health visitor will be asked to just kind of potentially follow up with mum, monitor, you know, give some kind of safety advice. But as mentioned, the right steps were followed by mum ringing 111. The ambulance saw the child, and had no safeguarding concerns. So closed with information and advice.
I'm quite surprised at that. Sorry, just to interject. Coming from a hospital perspective, we get referrals in all the time for children that are not independently mobile, just to be on the safe side and go through that history. So I'm quite surprised that that was the outcome for that decision. I mean, obviously I don't have all the information in front of me, but
I believe the hospital safeguarding lead was consulted, and the decision was made jointly with them, following a review of the medical history, and the child had attended hospital. I believe from the ambulance took the child to hospital, so the child had been examined.
Okay.
And they'd had a full sort of medical assessment.
That's fine.
That decision
I would
was
have
made.
been a bit more worried if that child was seen at home and not brought for further. Yeah, that's fine. Thank you.
I appreciate that. I believe, and I think that obviously added to the decision making was the fact that not only had the ambulance not referred, but hospital also had not referred when the child had attended at hospital, which is usually a good indication for us if we've missed 2 points of referral there, that there is a reason we're not getting that referral. So we clarified that, as I said.
I think also for the audience to be aware of the fact that we have a non-independently mobile baby policy. So, you know, we do get lots and lots of referrals in for unexplained marks or bruises from people out in the community, so that we can go through that process and make sure that it is as robust as it possibly can be.
And as a general rule, any injury to a non-mobile baby would automatically be taken in as a red assessment and dealt with very, very quickly, and as standard. And a lot of them, as this is an example of, are quickly downgraded once we've done those sort of checks and we know that they medically are fine and well, and that there's no other safeguarding concerns have been raised. But obviously there are occasions when that's not the case also.
Can I just ask, I'm a GP, and I would just wonder what information goes back, not necessarily to the GP because they weren't the referrer on this occasion, but that goes in the medical records. So things get coded, don't they, as referred to MASH, and then we often get we're getting more and more tasks and things back now to say that it's been dealt with in the MASH. And I've seen 2 or 3 this morning that say advice and guidance given, but there's nothing more than that really. You know, so on this occasion, this case, that they were fully assessed and there weren't concerns, it's kind of worth that being somewhere, isn't it? Because otherwise that's going to be potentially an ongoing safeguarding concern in the future, because we can't put it to bed without the appropriate information being there.
Yeah. I mean, it's going to be difficult for me to answer the question, if I'm perfectly honest with you, because our MASH health team do the feedback to any health professionals. But what I can do is obviously pass that message on to them. I'm not sure what their levels are of what feedback is put onto System 1.
Not much.
Yeah, that's what I'm sort of gathering. So I can definitely feed that back to them as an outcome of this.
Thank you.
To let them know that that's obviously a view that they might want to consider.
Yeah, because the other thing is then, as it was corrected in the end, that the kid was taken, but otherwise I'd worry about, so whoever the ambulance person was, you know, so the ambulance technician or paramedic at the time, if their decision stands and then MASH ignore it, not ignore it, sorry, but don't even talk to mum based on that, it's a lot of responsibility then for an ambulance person or a GP or the GP teams, if we're getting contacted by MASH Health, to then put on that person who probably isn't specialised in safeguarding things, isn't it? So, you know, I'd kind of like appreciated the reassurance that there was more a collaborative thing. So yes, the ambulance weren't concerned, but also the hospital weren't concerned.
Yeah, I think I'd be fair in saying that ordinarily is the case, that we will have done those checks, particularly for non-mobile babies, all the way up to the safeguarding leads at the hospitals. But it could have, you're 100% right, it could have been clearer, and that feedback to yourselves would have been useful for sort of any future needs for the child.
But we would have got the notification of attendance at A&E for the child in health, wouldn't we?
Yeah.
Zoe?
Yeah, we would, but they don't say much, do they? They say that they were brought in and discharged, really. There's rarely more than that, is there?
I think it's variable.
Yeah.
Some have little information on them, which is slightly frustrating, being the person who works in the hospital, and some have quite a lot of information. But you know, if you have any concerns, you can always contact us. Or
who are you? Sorry, the hospital, A&E, or MASH?
I'm the name nurse for safeguarding children.
Okay.
Right.
Thank you.
We'll move on to the last case study then. So did we have somebody from, so it's room 5, isn't it, we're up to? Is there anybody available? No. Okay, I'll just go through then. So this case study was for
Millie,
Charlotte.
I'll say something if you like from room 5, because we definitely did talk about this case study. So we felt that on the basis of what we had on the screen there, this would probably be going in into a level 4 in terms of the threshold matrix, because they're already in police protection following concerns about the neglectful and unhygienic conditions. Also, Charlotte's reported domestic violence between the carers, the grandfather and grandmother. There's also a disclosure from Jack as well of of physical abuse potentially. We've only got what the grandmother is saying about the mother in terms of the heroin use, but you would certainly want to know more about that before the children were returned to her in another local authority. So we felt, based on what we had on the screen, it was, we thought a level 4.
Yeah, and you're again on the nose with that one. So the case was triaged as a level 4 and a red, and a threshold discussion was undertaken, which included the local authority where mum was resident also. The decision had been made by the family to return the children to mum where there had been previous concerns. but we'd obviously got a number of incidents in this local authority. When a child is taken into police protection in Suffolk, we will, I think, always hold a threshold discussion. That is the process that we would follow to inform our next steps. For this one, we recommended that a joint Section 47 inquiry was undertaken on all 3 children, particularly with the disclosure from, was it Jack, that the grandfather had strangled, and I believe that was undertaken by the other local authority, given that the children had gone back to mum's care and they had a desire to further assess that anyway, as to the sustainability of that arrangement and whether it was suitable. So again, perfectly on the nose with where that should be. Okay, so thank you for everybody for your feedback and for obviously really useful points on all of them. I think they're quite useful exercises, in my opinion, just to show sometimes the limit to the information that MASH do receive. So these are very good examples of having some limited information on occasion at the initial point, and how much we then have to gather to actually bulk that out and make a decision that's proportionate. Some really good questions and sort of suggestions on what inquiries would have been made. I'll whiz through. We've just got a couple more sort of slides left, and then I'll open up for any questions. Really just some very brief ones. So what makes a good referral into MASH kind of covers what we've just been sort of mentioning. It needs to be clear and concise. Basic information for family members, including up-to-date addresses and telephone numbers, will always aid us. Clearly what the presenting issue is. We don't want to be bogged down in too much of a trawl of the history, although the history is of course useful. We need to very clearly be able to see what the current presenting issue is so that it doesn't get lost. The impact of this issue and the timeframes of that risk. So what impact is it having on the families right now? What impact is it likely to have from a viewpoint of a professional usually who's got more contact with that family than we would have? Any underlying needs that might impact on their level of support that is needed, the existing network of support. Again, that's really important for us to know whether there are family members that are supporting and can possibly be another source of information for us, particularly if we've got, for example, grandparents or aunties and uncles who are playing quite a big role in that child's upbringing. They often can give us quite valuable information into how things really are going in the home. And what level of support they're having to put in. Consent from parents, obviously, if it's appropriate, to inform parents of the referral, it's always beneficial to do so. Otherwise, we often blindside them with phoning them to talk to them about the concerns, and it often can sort of contribute to damage in relationships with professionals they're working with. Obviously, if it's not appropriate to obtain consent, for example, if a parent is a suspect of an assault on a child, we'd expect you to not necessarily inform them of that referral until that's been fully investigated. So it's a bit of a risk balancing game for sure. If you've ever got any concerns, obviously feel free to seek some further advice from MASH, and I'll go on to that in a minute on how you can do so. The other very, very important part is the voice of the child. It's something that we're often missing. We do our best in MASH to seek that, but that's quite difficult to do when we don't have that face-to-face element. Obviously, we can speak to a child over the phone if they're old enough and we feel that that's suitable, but often that's not, particularly with the younger children. So anything that can contribute to how this is impacting on them and what they feel about their situation and their lived experience is really vital to our decision making. So a little bit of a plug for our professional consultation line, just that if you ever do need any advice on whether a referral needs to be made, or again whether you need to be seeking consent is an appropriate thing to contact about. You can contact the professional consultation line. We now have a phone number and also a web chat which is available for professionals to use. Purpose is definitely to obviously gain advice on whether the referral is required, but like I said, the consent issue is something that we can also discuss over with you. You will be connected to one of our professionals within the MASH to talk over any concerns that you have for a child, and how sort of what next steps you need to take. It gives an immediate access to some advice and guidance around applying those thresholds when needed, and hopefully saving time and resources for everybody involved. This line's obviously, as I've said before, MASH deal with unallocated cases within CYP. So if it's a case that's allocated, you will need to go to the child's allocated worker. But for unallocated cases, this number is available, and as is the web chat facility, which you can access on Suffolk Safeguarding Partnership website. And that is, I think that's us done. So is there any questions at all?
Millie, can I ask a quick question?
Of course.
So in one of the case studies there, you referenced a really good piece of joint working between two local authorities.
Yeah.
We've had a case recently, I won't go into the details, but where it was a sort of split family with children across two local authorities. And so they moved in with the parent that was connected with one of our schools. I suppose my broader question is just, and then the two local authorities were sort of ping-ponging as to who would take responsibility. My broader question is just, how do you find that? How do you get on when you're trying to work with another local authority, and where the responsibility lies?
Yeah, I mean, it's a challenge, to put it bluntly, Steve. It's different depending on which local authority we're dealing with and the circumstances of each case, if I'm honest. We try very hard in MASH to maintain the best relationships that we can with our counterparts in other local authorities to make that as smooth as we possibly can. And that is all sort of we can do, I think, at that point. But it is a case by case. Sometimes there's more challenges. Sometimes it's a very straightforward and smooth process.
Yeah, thank you.
No problem. Got anybody?
Can I ask a question? Oh, sorry, I'm cutting on somebody. It was just a quick question that one of the staff asked me and I didn't know the answer. So it clearly says in the threshold document around unaccompanied asylum seekers, but what about children who do come with their families? Is the kind of idea, if they are asylum seekers or refugees, where does that sit as far as referral and understanding that they've come through what is likely to be very traumatic experiences anyway, or is there kind of like a separate team or a separate pathway we should be following, or a separate pathway that someone else is already following that we may not know about, like the Home Office or something like that?
Yeah, so again, hit the nail on the head. The Home Office do have their own processes in place around that, and they have their own support network that they can offer out to families who are accompanied children and asylum seekers, for example. However, if there's a safeguarding concern for that family and they're in our area, or there is an additional support need identified, it may be appropriate for you to put a referral in. Again, you can seek some advice on our professional consultation line if needs be, but if it's an immediate safeguarding concern, that would require a MAF. Have we got Anthony? Did you want to say something?
Yes, just a point, Millie, about the professional consultation line. And we made a decision at the Partnerships Executive, coming out of an appreciative inquiry, that we needed a community consultation line as well as the professional line. And Seb and Jackie Wilkins from CAS are trying to take that forward. And I suppose it's been brought into even more importance because of the Arthur Levin-Joe Hughes review in Solihull, where relatives had concerns and sent photographs in but were disregarded by the police and social care. Now, I had some assurance from Seb, and that's before the handover to Rennie, that in fact, if you were a volunteer in a small organisation, you could actually use the consultation line. But even in your paperwork today, it limits it to being a professional line, and you wouldn't think you could access it if you were working in a small community facility. Very worried about a safeguarding issue, but not wanting to make a referral. So could you just clarify the point about whether it is also a community line, and if so, whether that can be publicised in order to make sure it's more accessible.
Sorry, I've just lost power to my laptop, so I'm hijacking Emma's connection.
Oh, okay.
So I apologise for that. But yes, you're 100% right, Anthony. It possibly needs rewording. It is open to voluntary section. It's open to people who are working with children. I think the way that it's been worded was purely to identify that it's not for the use of family members at this stage. Obviously, there's plans in place, as you've just mentioned, for that.
Yeah.
But yeah, it is anybody who is working with a child or young person or their family can contact us on the professional consultation line.
Can I suggest you just rebrand it to appropriately reflect that it could be professional plus professional and community consultation line, something like that.
I can definitely put that idea forward.
Thanks.
No problem. Have we got Zoe? I think you've got your hand up.
Yeah, cheers. Just a kind of question of how do you within the MASH or / how could we within health or anybody really identify whether children are already allocated to CYP that we could then contact directly? So it's kind of probably again about feedback from, we get the text back these days or the tasks back to say that the MASH outcome has been a section 17 or a section 47 inquiry, but then very, very rarely hear anything back to say if there's a social worker involved, if they're referring on to the young people's partnership or what the support is. So if there's then a new question about that kid, it's really difficult to know probably what was the outcome of the previous MASH inquiry or who's involved really. I wonder whether if there was a way of centrally accessing that could potentially prevent quite a few referrals into MASH. The case studies have kind of nicely demonstrated where things were needed, but I suspect there's a great deal where actually, the outcome was that nothing needed to be done because the support was already there, just nobody knows that somehow.
Yeah, I mean, obviously, you can always contact customer first, who will be able to advise you if there is a allocated worker. They will also direct any MARS or any other sort of contact that they get in to an allocated worker if there is one in place. And I believe that there is some work ongoing to look at making that a little bit clearer, but it's been very early stages at this point.
Okay.
Sorry, I can't. Has anybody else got any further questions? No, fantastic. Okay, well, thank you everybody for attending. And I think that's a wrap up here for us.
Yeah, thank you, Millie and Emma. That was really, really useful. That's really good. Just to say, there have been quite a few people in the chat asking about the slides. Is that possible to send the slides to everybody?
I believe the slides are already available on the Suffolk Safeguarding Partnership website for access. But yes, again, if needs be, they could be sent out, but they are already available on the website for.
Right. Okay. Amy must have put those on there. Okay, that's great. So yeah, so people can just go to the Suffolk Safeguarding Partnership and you'll be able to access those. And just to say, we have recorded this, so this will go on to. Eventually it'll go onto our YouTube channel, Suffolk Safeguarding Partnership YouTube channel, so you can access it again on there. And then we are going to do another one, a repeat one, sometime in September and October, because we're very aware that a lot of schools missed this because obviously it fell after the end of term. So again, if people want to, and that'll go, details of that will go out when we put the date together. But thank you very much, Millie and Emma. That was really, really helpful.
Thank you for having us.
Okay, thanks everybody.
Thank you.
Thanks, Tracy.